Good evening, one and all. This is Satish Joshilkar from Zydus Life Sciences. I would like to welcome all for this scientific feast called CLEARTalk. On behalf of Zydus Life Sciences, I would like to welcome our today's eminent faculty, Dr. Bijay Prakash Pandey sir. Without wasting much of our time, I would like to give a brief introduction of sir. Sir is MD DM Cardiology. He is a HOD and Senior Consultant Cardiologist, Narayana Hospital and Heart Care Clinic, Hora. And he is the one of the best faculty available here to give us a talk on bempedoic acid through the lenses of clear outcomes trial. Without wasting much of our time, I would like to hand over the session to Dr. Bijay Kumar Pandey sir. Thank you, sir.
Thank you. Thank you, Satish. Good evening, friends. We are here to discuss about the management of lipid with a special reference to bempedoic acid. And as you know that we have a now outcome data known as the clear outcome data. So in that context, we'll be learning and sailing through how to manage lipid, abnormal lipid, I mean to say, and LDL in particular. So just a brief introduction, how LDL is important and how reduction is going to be important. We know that if you reduce 1 millimole per liter of LDL gives you almost a 21% reduction in cardiac events. And this we know since the era of the statin. So reducing LDL is an important goal, and how much we can go low, I think there is no limit. So people have tried even up to 15 milligram percent, as you know, in one of the PCSK9 trial, and lower the LDL, better is the outcome. So it has already been a proven fact. The question is not that. The question is, how do we come to that level? That is important in day-to-day practice. So priority is to bring down the LDL. Means are probably not that important in 2023. So available agents which we are using over last 40 years or so, are they able to achieve the EC, ACC, ESC, or even Lipid Association of India guideline, which is, by the way, much steeper what you read in the Western guidelines. So how often you are able to achieve, what are the means to achieve, we will discuss during the next 30-40 minutes of time. So the concern is, do all statin users achieve their LDL goal? And we'll come to see. So LDL cholesterol, you look at the all the trial data which has been depicted here from the very beginning to almost PCSK9 ODC data was published in 2020 or 21, I think. So in this scenario, if you look at the relative risk reduction of the cardiovascular events, it has been amply clear. Whatever you do, if you are able to reduce by 39 milligram percent, you will achieve a significant benefit. And nowadays, it is not only the level which you achieve, how quickly you can achieve. That means how number of years you have a high LDL is nowadays also important. So just like we learn in a P time INR, the time in therapeutic range, now the concept is what is the range of LDL and how long you have been into that ideal target. So what are the target? I think just to recapitulate the ESC guideline, for a very high risk, it was below 70, and we have come down to less than 55 as per ESC 2019. And this guideline in Lipid Association of India is 30. So the target is really very steep. So it's not 70, not 55, it is below 30. In fact, someone who has got a 2 MI in 2 years' time or multiple interventional procedures, their target is closer to 30. When we are born, our LDL cholesterol is around the level of 30, 35. And in a disease state, we want to achieve that so that not only we halt the progression of the disease, but also we get regression. And in other risk factor, there is some leniency. But the rule of thumb is whatever the LDL cholesterol, you have to bring it down by 50%. That is the first target. And the second target is the goal, which is set by all the societies across the globe. And Lipid Association India is no exception to that. So if you want to bring to this level, we'll see what is the current scenario. So based on the 2019 European Society guidelines, you have to have a better control of LDL. That is the most important. And we'll see from various registry data, because these are the real world experience, and you'll be surprised what we do in hypertension management, almost similar stories with the LDL. So this DaVinci study is one of the pointer towards that, because in this registry data, we can see that only 27.6% eligible patients are receiving high intensity statin. That means you have the substrate, you want to reduce it, but this percentage is only this much. And out of that, only 30% will go and achieve the target. So we are really not doing so much well, despite having at least 4 drugs to our command, and still such is the situation that not only we are picking up a less number of patients, and when we are picking it up, we are not treating to the target. Even if you are treating to the target, we are not maintaining the target, because this, as a clinician, I find once a goal is achieved, there is tendency to reduce the doses of a statin. Oh, okay, now it's come down. Either they will stop it or they will cut down by 50%. So that's the wrong practice. So the uses of statin should have been much more intense, and we'll discuss how now we approach in 2023 in a little bit of time. So the DaVinci, this study has shown that eligible patients are not able to achieve target in at least majority of the patients. Reason we'll discuss. One, there is a perceived side effect of the high intensity statin. High intensity statin means you have to reduce LDL by 50%, either by 80 milligram of atorvastatin or 40 milligram of rosuvastatin. And the guidelines mandates that you recheck the level, step care approach. If not on target, you add ezetimibe. If not on target, then you add a PCSK9. And now another kid on the block is bempedoic acid. So a little bit discussion about the pharmacology of this new molecule, which is a once daily medication, because half-life is closer to 24 hours, and majority of the excretion is through kidney. So less than 2% excretion of the unchanged drug through the kidney. So what happens in renal impairment? There is no dose adjustment necessary. And even in a hepatic impairment, at least up to child PUC class A and B, there is not much of a concern with the doses. So most of the patients, unless you have hyperuricemia, you have to watch out for a uric acid level. You have to look out for certain features where there's a tendency for tendon rupture, particularly the amyloid disease and all. So it will exacerbate the tendon rupture. Certain interactions with the quinolone type of antibiotics where there's a tendency of a more tendon rupture. So these are the fewer side effects which probably are not that relevant. So initially, since the publication of the various data on the bempedoic acid, we did not have a clinical outcome data, and that was put to rest with the publication in the last American College meeting. And we have this clear outcome data, which was a positive one. So the cholesterol lowering via bempedoic acid, which is acting on your HMG coenzyme pathway, it is an ACL inhibiting regimen, has done the trick. So about the design of this study, this is the cardiovascular outcome study with the bempedoic acid in statin intolerant patients who have elevated LDL cholesterol. So those intolerant patients had a screening to begin with, and initially it was a primary and secondary prevention group of patients with statin intolerance. And after a run-in phase with a single blinded placebo study, this trial was designed. So the bempedoic acid was given at the standard dose of 180 milligram per daily. 7,000 patients were there. Subsequent visit was done at 1 month, 3 month, and 6 month, alternating a telephonic contact, and the clinic visit every 3 months thereafter. And the comparator arm also had a 7,000 patient. What was the endpoint? The effect of bempedoic acid versus placebo on a 4P, that is the cardiovascular mortality, non-fatal MI, non-fatal stroke, and coronary revascularization. You have to have 1,620 primary events in at least 2 years. So this was followed up for around 40 months. So this is the basic trial design of the CLEAR outcome data. And we'll show you the demographic profile. The mean age of both the arms were around 65 years, a BMI closer to 30, and the mean LDL cholesterol level was around 139, with the CRP mean 2.3. Most of these patients had around 60% the normal eGFR, and 20% had below 60, and another 79% had hyperfiltration, that is more than 90. So majority of the patients, that means around 77%, had in the normal range of eGFR. What was the most of these patients had been given for secondary prevention. 30% patients were also as a primary prevention cohort. And out of the secondary prevention, half of the patients had coronary artery disease, another 11% peripheral arterial disease, and 14% cerebrovascular atherosclerotic disease. A good 45% of this population was diabetic, and inadequate diabetic control was in 19%. The statin use was only in 23% of the case, and ezetimibe use was 11%. So it wasn't absolutely no statin therapy, but those patients who were intolerant of statin, they were enrolled, but certain amount of statin use was there, as is mentioned here. So the primary outcome, 4-point MACE and 3-point MACE, relative risk reduction was significant. And the fatal, non-fatal MI risk reduction was also 23%. And coronary revascularization reduction was also significant, with the p-value being less than 0.05. So you can see the tabulation of all the 4-point MACE. Everything you can see, the bempedoic acid has a relative risk reduction to the tune of around 23%. So look at the fatal, non-fatal MI, the hazard ratio was 0.77. Look at the this one, you have hazard ratio of 0.87. So similarly, you have a significant value for other points also. So it was statistically a significant result with this. Coming back to the background of this, because as I said, initially we are giving a statin. Some patients will complain of muscle pain, myalgia, what we call statin-associated myopathies. Because of the SAMs, we could not reach the optimal dose. Sometimes we switch from one statin to another statin, and sometimes if there is enzyme rise, CK more than 10-fold, we take a step back and reintroduce with the lower level. And ultimately, if you cannot give any dose, then you have to think of giving ezetimibe or PCSK9, and nowadays inclisiran, which has been approved in Western world. Trials are going on in few of the centers in Calcutta also for inclisiran. Enrollment has already started. So we didn't have an oral therapy option apart from ezetimibe, but with this publication of the clear outcome data of this ATP citrate lyase inhibitor, that is stands for ACL inhibitor, will tell you in what clinical context we are going to use it. So basically, this was important that both the molecules has been tested, but clinical outcome data was published only this meeting few months back. And it was basically a hierarchical testing of secondary endpoints were also done, meaning thereby that if you have achieved the primary endpoint results and then one by one, the other secondary endpoints were also analyzed. So from 4P to 3P, and then the cumulative secondary endpoints, including cardiovascular death, all-cause mortality, were also assessed. So effect of the trial regimens on this event among the intolerant patients, the treatment with bempedoic acid was associated with a lower risk on all the fronts, as you see in this presentation, that 4-component MACE, 4P MACE was reduced by 13%, 3-point MACE was reduced by 15%, MI was non-fatal MI was reduced by 23%, and the coronary revascularization was also reduced by 19%. So the clear outcome data has shown that if you have a 21% reduction in LDL cholesterol with bempedoic acid arm, it is also acting as anti-inflammatory marker. You have a 22%, look at the yellow bar at 6 months, 12 months, and end of the trial, you have a significant reduction in high sensitivity C-reactive protein. So it not only reduces LDL, but also improves the inflammatory marker, just as we have seen with the statin, particularly the rosuvastatin trials. Is there any price to pay with this molecule? The serious adverse events were only few. In fact, it was comparable to the inactive arm. Discontinuation was 10% in both the categories. Here you can see. Myalgias were also comparable. New onset diabetes mellitus was not significant, unlike statin therapies where you get 9% chance of new onset diabetes. Renal impairment was numerically higher, but not significant. Hyperuricemia is an issue, so one has to be a bit cautious if you are dealing with the patients of a gout or any other drug which increases hyperuricemia, so just be on guard. But this is not a contraindication to start therapy with this molecule. So baseline changes was to this tune. So hyperuricemia and in some cases a biceps tendon rupture has been reported, but I think just we have to be aware of it, but not absolute contraindication to start with this molecule. So it becomes the first ACL inhibitor and first oral non-statin to demonstrate a statistically significant reduction of 4-point MACE in patients who are at high risk for CABD. As you know, 70% patients were taken as a secondary prophylaxis. So after statin and ezetimibe, we have got another molecule, because as you know that PCSK9 is a very costly affair. It costs around 17,000 rupees per injection. You have to take twice in a month. But if you have seen that with the moderate doses of rosuvastatin, a full dose of ezetimibe and a full dose of bempedoic acid almost does what the PCSK9 does. If you use these three combinations and majority of the cases you'll have a 60 to 65% reduction in LDL level. And what we need is actually more than 50% reduction. So in our practice, we are using it. In fact, before the publication of this clear outcome data, we are very happy that in those patients who are on the full dose of statin and ezetimibe, if they are not to the target, we are using bempedoic acid to achieve target, unless your patient is a heterozygous hypercholesterolemia, because in that cases, in that scenario, probably we need to add PCSK9 as well. Otherwise, if your LDL is around 150, 160, most of the time, if you calculate 65% reduction, you will be down by up to a 60, 62 milligram percent LDL level. So moreover, it's a well-tolerated drug. It is also an anti-inflammatory drug, as we showed that around 20% reduction in high sensitivity CRP. So primary and secondary prevention patients had this positive outcome data based on both primary endpoint as well as a hierarchical testing of the secondary endpoints. So I believe that if you are faced not only with the side effect of the statin, but also the potency of the combination of statin ezetimibe, this drug is going to be helpful in achieving LDL target without injectable therapy like PCSK9. So thank you very much for the patient's sharing. So if you have any question, I'm more than happy to answer this.
Thank you so much, sir. This was a wonderful presentation. I hope I am audible to all of us.
Yeah.
Yes, sir. So there are a few questions in the chat box. I would like to ask those questions, sir. This first question, which is initially you talked about ESC 2019 guidelines, and they were talking about LDL cholesterol reduction up to 55 milligram per deciliter. But how safe it is to bring down this LDL cholesterol? Even Lipid Association of India has also strictly said that LDL cholesterol should be less than 50 milligram per deciliter in very high risk patients. So what is your take on it, sir?
Yeah, as I said, Lipid Association India in extreme high risk, the target is 30. So non-HDL cholesterol has to be around below 60. So target is much, much steeper what the ESC 2019 has said, and it is achievable. In fact, if you have gone through the publication of the Odyssey outcome data, where one of the contraindications where if your LDL cholesterol is below 15, you have to take off the CUMABs. And it has been seen that in those ultra low LDL cholesterol patients actually had a legacy effect. So if you are down to that even lower level, and if you can maintain, because alirocumab was given for almost 8 months before they could withdraw because of the LDL getting below 15, in that quartile of patients who had a LDL below 15 had a better long-term outcome. So now, just like in diabetes, this legacy effect is also in statin. So some patient who has got LDL cholesterol high for 2 years, maybe it is 180, I'm not that bothered, compared to a patient who has got LDL cholesterol known 140 for 10 years. So that patient is much more higher risk, and where we'll go all gun blazing, including if needed a PCSK9, because the first target is you bring it down very rapidly. You can always de-escalate. Say someone goes below a target and still they are maintaining it. You may reduce the first or most offending drug if you want to, depending on the socioeconomic. So the concept has to be drilled into the physician's mind that once you achieve LDL cholesterol, at no point in time you are going to reduce the dose of that particular effective drug.
There's a question attached to this. Is there any neurological complications if we go under 30 milligram per deciliter like that?
Yeah, so this is another important question, and I'd like to convey this, that brain cells are not dependent on what is your LDL cholesterol in the blood. They synthesize their own. So it doesn't matter what is your level. And in all the trials, it has been shown, even in neurological trials, there is no accentuation in dementia. In fact, the pre-senile dementia will be much less if your LDL cholesterol is on a lower side for a longer period of time. And probably you need to give some anti-inflammatory drugs so that the dementia is also reduced. And these two molecules, at least the statin and bempedoic acid, have got remarkable anti-inflammatory effects.
Very nicely concluded, sir. There's one more question related to, I have many patients with diabetes and hypertension. So what LDL target should I keep in mind for these patients?
So for particularly if you are talking of hypertension, we always go for some form of scoring. And if you do a scoring, and according to the score which I showed, if your patient belongs to high risk or moderate risk, you set your target. So it's like mathematics. If my LDL cholesterol is 140, I have got a hypertension, I am a diabetic for 4 years. So most likely I am going to be into the high risk. So two risk factors, cholesterol high, no events so far. So probably I'm into the high risk. My target is definitely around 70. So from 140, if I have to get down to 70, it is a 50% reduction. Now we know which molecule will reduce 50%. Atorva 80 milligram will go, say, around 40%, rosuvastatin 40, around 40%. So one drug is not going to be sufficient, most likely. So probably I'll start with another molecule, either bempedoic or ezetimibe, and try to get below 50% reduction. And later on, once the patient has his weight loss, exercises, all those additive effects, so probably one of the molecule I may withdraw. So that is how I practice. So it's like a mathematical model, may not always be correct, but for the beginning, it is very important. So no point you have LDL 180 and you start with 10 milligram rosuvastatin. You are going to fail and patient will have multiple visits. So nowadays, value for money is reduce the number of office visits. So plan it, prescribe it, so that next visit, oh, doctor is so good, he got it down to 40 or 50, whatever is the target.
Sir, this next question which is being asked is, if patient is having elevated LDL with moderate statin dose, then what should we do? Either we should increase the dose of statin or directly add bempedoic acid or ezetimibe to this patient.
So yeah, as a purist, always we'd like to increase the dose of statin first, unless he has got SAMs, like symptomatic myalgias and all those things. So the guidelines are guidelines. I think we need to stick to that. And once, as I said, you fail with that, probably you'll add another molecule. The approved molecule is ezetimibe. I don't know DCGI has given permission in ACS or not. So we have to look at the local guidelines. If there is no guidelines, the guidelines will be included. So that is how we should work. Exceptions are, if you are dealing with acute coronary syndrome, nowadays even the Lipid Association of India asks you to add from day 0 statin with ezetimibe / bempedoic acid. So you go very early, very hard, and later on de-escalate. So in stable condition, you are free to go to the highest dose of statin and then take step care. In acute patients, you go, as I said, most of the drugs at day 1, and at 2 weeks or 4 weeks interval, you assess the lipid, look at the non-SDL cholesterol, look at the triglyceride, and take a call.
So you have spoken about a clear outcomes trial in statin intolerance, and the question is about statin intolerance, that you observed how much percentage of patients you observe in your routine practice of statin intolerance, and
I think
how you identify this statin intolerance?
frankly, I'll tell you, less than 1% in my practice over last 30 years I have faced. Only thing is perseverance. You have to make them understand that all muscle pains are not due to statin. So probably they have some vitamin D deficiency or something. If someone has a persistent symptom, look at the CK level. If it goes more than 10 times, then only. So it's overdiagnosed, and unless there is rise in CK to that extent, usually I do not de-escalate. So as I said, less than 1%. Those who take a lot of alcohols, they have more prevalence. This I have seen. More the educated patient, more statin intolerant. This is also seen. If patient happens to be a doctor, more likely you'll get a statin intolerance. So these are all the nitty-gritties, but it's not so common. And nowadays we have got the molecule. If someone is really after you, you have got the evidence-based medicine to add on. That means, so all the trial says, patient on tolerated dose of statin. No one says on a high intensity statin. They say on the tolerated dose. Even in Fourier, even in Odyssey, these are all tolerated dose of statin, which might vary from 20 milligram to 80 milligram of atorva, or 10 milligram to 40 milligram. So you have to take a call. Patient has to take the medicines.
Thank you so much, sir. This next question which they are asking about, there is any benefit of bempedoic acid or in newly onset of diabetes mellitus, or what is your take on, like, statins are being talked about, the increasing chances of patient getting diabetes or worsening of diabetes?
Absolutely. So as I said, there's a 9% reported incidence of new onset diabetes with a statin. The least is with the pitavastatin, where it has been reported around 2%. So someone, my take is someone who has got impaired glucose tolerance, who has got a higher tendency to get into frank diabetes or metabolic syndrome. I think you have to be wary about new onset of diabetes. And if they are not following the lifestyles, and now we have got another molecule, and which is evidence-based with the clear-cut outcome data. So the things might change. But only thing, you have to achieve the LDL target. I think mean is not going to be important in future.
So there's always talked about this is my personal question to you.
Yeah.
We have been talking about LDL cholesterol reduction. There is always a different side of triglycerides, which are increased triglycerides. So nowadays it is being said that LDL cholesterol reduction is more important uh, as it decreases the residual risk. So what is your harping on this?
Yeah, as I said, guidelines are clear cut. You first tackle the LDL cholesterol. Once your LDL cholesterol is at goal, look for the non-HDL cholesterol, which the lipid association says in very high risk, it has to be below 60. So if you take care of the non-HDL cholesterol, that automatically take care of triglyceride. So if you are not talking in terms of LDL and non-HDL cholesterol, let's talk about LDL and triglyceride. Someone who has got triglyceride below 500, don't be bothered, because none of the medicines treating triglyceride is going to improve outcome. There is a lot of controversy regarding the reduced heat trial with the these fish oil, icosapentaenoic, whether the comparator arm was more harmful. So the dubious benefits, the debate is still going on. So unless your triglyceride is above 500, don't be bothered about triglyceride. So as clinician, target your LDL. Once you are at goal, measure non-HDL cholesterol and try to bring it down. Fortunately, these molecules, both ezetimibe and bempedoic, they also have a 9 to 10% reduction in the triglyceride levels. In fact, all the statin therapies have this benefit to the tune of say 9 to 11%, even PCSK9. So if you are not on target and the further trial proves the concept that a reduce it study was a beneficial one, so probably in those patients, you are going to give a 4-gram icosapentaenoic acid. So that is how we perceive it.
Thank you so much, sir, for adding such a valuable your in-clinic experience to this talk and giving your practical insights so that the audience also get benefited out of it. Before we conclude, anything you would like to say as a conclusion remark and take-home message for all our delegates?
Yeah, so this is important that once you get a patient to your clinic, don't lose the opportunity to check lipid profile. He might have come for some other symptom. So as a preventive cardiology, you look at the lipid status at least once in their lifetime. So that is number one, because you might lose this opportunity. Regarding the fasting and non-fasting cholesterol, nowadays nobody has a time. At least if patients are not fasting, you get a non-fasting lipid profile, and that has also come into the guideline. So we have also seen any patient getting admission in hospital, they get lipid profile irrespective of the time they get. So getting to the first set of lipid profile is important. If you have a borderline lipids, next day you ask for 12-hour rigorous fasting and do a lipid profile. That is number one. Second thing is always remember what is your target to that particular patient, and that you will be able to achieve only if you know how to do a risk assessment. It's no fun treating a blood pressure number, no fun reducing HbA1c, no fun reducing LDL. Patient is patient. Holistically, you should know and learn one at least risk model, how to assess the atherosclerotic risk. You might use a Q risk, some other calculator which you are comfortable. Risk assessment nowadays is important because there will be few patients who are not keen on starting statin therapy, and we have to prove them that it is necessary. We might do a calcium scoring, we might do LPA, just to highlight the point how important it is to reduce LDL. So then they will get convinced. So someone has got a CAC score of more than 100, LPA is very high, 70, whatever is the LDL level, I'm going to give him LDL lowering therapy. So the risk assessment is important. So you have to be very clear in your thought process. Pick up the high LDL level. Once you pick up, you assess the risk assessment, put them into a very high risk, intermediate, whatever, write on your prescription, write your target, so that next visit you chase the target and try to achieve the at least first target. Just like we do a control fasting sugar first in a diabetic, we do a control LDL first target, and then next on you graduate to non-SDL. So that is how the medicine should be practiced in real world.
Thank you so much, sir. It was indeed a pleasure having you and honor having you on this event called Clear Talk, and clearing all our doubts about bempedoic acid, the usage of statins, LDL cholesterol management, and each and everything aspect you covered very nicely, sir. This was a very comprehensive session, and we are very sure that delegates who attended this Clear Talk would have got enlightenment from your speech on bempedoic acid, and as you have covered all aspects of bempedoic acid in your session. At the same time, we would like to thank all the delegates for their active participation and patient hearing. Would like to ask our zonal head, Mr. Ayanda, to give vote of thanks. Thank you.
Sir, on behalf of Zydus, thanks from core of our heart for your lucid presentation on this, not only for bempedoic acid or clear outcome trial, but also all the pros and cons for this LDL management and usage of bempedoic acid and all these things. So I would also like to thank all the esteemed delegates for their patience hearing. So we as a Zydus presence in the market of bempedoic acid from very beginning, and I request all the delegates, all the esteemed doctors to try this bempedoic acid, as we are having this post-marketing surveillance trial for this bempedoic acid. So please use this bempedoic acid to set off your patients and try to find out, and as a organization Zydus, we give you the utmost we give you the utmost confidence that we'll even publish this data in a trial form, in a booklet form, or in a scientific paper for your this trial. So please try out this bempedoic acid, Bemdac. We have our Bemdac, Bemdac EZ, and Atorva B also available in this market. So please try out and let see that how the result is. Thank you for all. Thanks to all my colleagues for this assembling all these esteemed delegates for this clear outcome trials. Thank you.
Thank
Thank you so much, sir. Have a nice day. Have a wonderful evening. I
Thank you for having.
request all the audience, be safe as you are the asset for the India. Thank you.